Dear colleagues, this is an intumescent cataract done today, the 30th December 2016. As we know, in intumescent cataracts, the intralenticular pressure is high and there is high chance of Argentine flag sign. I do a minirhexis first in these cases, and then I enlarge the rhexis to an optimum sized one. I do not use any cohesive viscoelastic substance in these cases. I use only HPMC, hydroxypropyl methyl cellulose. This is the left eye of the patient. By this time, main incision and on-site port incision on the left side of the main incision has been made. Now trypan blue dye is being injected underneath an air bubble to stain the anterior lens capsule, and within 4 or 5 seconds I wash the dye out. And now viscoelastic substance 2% HPMC is injected into the antechamber. Now one side port is to be made on the right side of the main incision. Here it is. This is the paracentesis incision on the right side of the main incision. Now I take a bent cystitome and incise the capsule like this. Here it is. It's a curved incision, and in this kind of incision the risk of Argentine flag sign is minimal. I take a ureter forceps and I make a very small rhexis on the dome, or rather on the anterior pole of the capsule. Now I take a Simcoe cannula and aspirate the superficial cortical matter. I squeeze the cortical matter, bring it to the center and aspirate it. You can use a bimanual IA to aspirate this cortical matter if you do not have a Simcoe cannula, or if you are not habituated to use Simcoe cannula. When you have aspirated some cortical matter, the character of the cataract is changed, totally changed. It is no longer an intumescent cataract. It is just an ordinary cataract. Viscoelastic substance is again injected, and I give a cut at the margin of this minirhexis with a Vannas scissor. I take ureter forceps again and enlarge this rhexis to an optimum sized one. All of us should practice using ureter forceps. You don't know when it will be necessary in your surgery. So capsulorhexis part is over. So it is very much possible to do capsulorhexis without using cohesive viscoelastic substance in intumescent cataracts. Now the tip of the phaco handpiece is introduced into the antechamber. The tip is embedded in the substance of the lens and the lens is chopped. The cataract is chopped. This is a nice cataract to chop. This cataract is having nuclear sclerosis of grade 3, and this is an ideal case for beginners to start direct chop. Those who are habituated to divide and conquer technique, and this density of cataract is ideal for them to chop. Now I take out the chopper and remove the last fragments so that the posterior capsule goes towards the vitreous cavity and the risk of catching the posterior capsule becomes minimal. Now in this case we can see that there is a very fine cortical matter which I cannot hold it with a Simcoe cannula. It's very difficult to hold this. So in this case what I am going to use is I am going to take my bimanual and irrigate this fine cortical matter. It's just like cells sticking to the posterior capsule. There is no fiber. So I will thoroughly irrigate this cells and make it loose, make it float, and then aspirate. Here it is. I am using only the irrigating probe and I am dislodging the cells from the posterior capsule. And now I am using the aspiration probe to remove these loose cells. Now I am irrigating this part and now I am removing the cells from 3 o'clock, 2 o'clock, and here subincisional cells are also being removed, but they need some irrigation. So I'm trying to remove it anyway. We have to be patient sometimes while doing surgery. Safety of the patient comes first. Now after cortical cleanup, viscoelastic substance is injected into the antechamber. This part of the video is edited. After cortical cleanup, it was not edited. Now viscoelastic substance is thoroughly removed from the antechamber. I first use Simcoe, then bimanual, and then the antechamber is formed and the case gets over. Thank you very much for watching. Hope this video will be useful in your practice.